One of the key promises of online health communities is the ability to connect with others who are having similar experiences. These online peer relationships enable mutually supportive communication. And as researchers, we want to design online health communities to facilitate the formation of these kinds of peer connections. Doing so requires an understanding of the specific individual factors associated with the formation and growth of peer relationships. In this study, we explored these factors in an online health community that lacks an elaborate technical infrastructure for finding and forming peer connections. This presents a unique opportunity to observe users' preferences for peer connection when conventional social discovery mechanisms like search and recommendation are almost completely absent. The platform in question is Caringbridge.org, a large online community that helps patients and their caregivers communicate about a health issue to their broader support network. Caringbridge sites function mostly like blogs, with authors publishing text updates for visitors to that site. Registered visitors can interact by leaving comments or likes on individual updates. And you can also leave special guestbook comments at the site level rather than in response to a specific update. We focused on the comments, likes, and guestbooks that were left by other registered Caringbridge authors, who function as peers to each other. We built a network from the interaction between authors using social network analysis to analyze their connections. These are the peer connections that are desirable and accessible enough to Caringbridge users that they form even without explicit affordances. We took a look at 4 high-level factors associated in prior work with the formation of online connections: the position of authors in the interaction network, an author's type and level of activity in the online community, an author's health condition, and an author's health role, which is a factor I'll focus on in this talk. By health role, I mean the structural expectations and responsibilities that arise from a health event that creates a patient and some number of non-professional caregivers. On Caringbridge, authors implicitly take the role of either patient or caregiver. There's a lot of complexity here with taking on multiple roles and switching roles that you can find in the paper, but functionally, we trained a machine learning classifier to predict an author's role from their site updates. What we found is that patients and caregivers interact differently. An author's role has a massive impact on whether they interact with peers at all, when they first start interacting, who they choose to interact with, how likely they are to reciprocate another's interaction, and the number of interactions in their relationships. We fit various regression models for each of these research questions, but here I'm just going to summarize the trends. So, who does interact? Among all authors, caregivers are more likely than patients to interact with others in the first place. But this pattern depends on others' interaction behavior as well. While receiving an interaction makes both patients and caregivers more likely to interact with others themselves, interestingly, patients get a much bigger bump, becoming more likely to interact than caregivers after receiving an interaction. Among those authors that do interact with others, when do authors first interact? We found that patients start interacting almost 5 months sooner after becoming an author than caregivers do. And as far as the target of those interactions, patients are more likely to interact with patients, and caregivers are more likely to interact with caregivers. We see the same behavioral pattern looking at who reciprocates an interaction. Authors are more likely to reciprocate when they share a role with the interactor, although this effect is much stronger for patients. Patients are more than twice as likely to receive a reply when they first interact with a fellow patient compared to interacting with a caregiver. Finally, if we look at the sequence of interactions between two authors as a relationship, relationships have more total interactions and are more balanced when authors have the same role. So why do we observe these differences between patients and caregivers? One useful way of thinking about these differences is as a combination of preferences and barriers. Patients and caregivers might have diverging preferences for particular connections, and so, for example, we can learn from health theory about the types of supportive relationships that patients look for online. Communicative or technical barriers might prevent users from enacting their preferences. For example, caregivers often feel uncomfortable asking for help for themselves, or may not know what to say to a patient. We see an opportunity here for qualitative work to focus on identifying and designing for these barriers. Finally, as correlational work, our findings need experimental follow-up. I'm particularly interested in how these results translate into recommendation systems designed to aid social discovery and facilitate peer-to-peer relationships. Should such a system take our findings as revealing a preference and aim to recommend primarily peers with the same role, or should we take our findings as revealing a barrier to cross-role communication that a recommendation system might be able to overcome? I'd love to talk more about this, so feel free to send me an email if you have any questions or thoughts. Links to the paper and analysis code are shown on the screen now. Thank you for listening.